I'm Dr. Van der Bijl presenting Lecture 3. Again, a reminder that I will emphasize core concepts in the PowerPoint. Please refer to the study guide and chapters in the textbook. Work through the case study and ensure that you have mastered the work by completing the multiple choice questions. At the birth of the baby, numerous cardiorespiratory changes take place in order for the baby to transition successfully from intrauterine to extrauterine life. For the respiratory system, the lungs need to be cleared from fluid so that the alveoli can fill with air and gaseous exchange can take place. Numerous disorders can limit and hamper this normal adaptation of the respiratory system. The severity and the clinical presentation will vary according to which part of the respiratory system is primarily involved. One can have primary lung disease leading to signs of respiratory distress. The immature respiratory center in the brain can lead to apnea, hyperventilation, and related bradycardia. There might also be upper airway obstruction, as babies are obligatory nasal breathers until they're about 6 months old, and these upper airway obstruction can then present with stridor. And then there can also be chronic respiratory problems. When evaluating a baby's respiratory system, it's important to note that respiratory distress refers to a cluster of symptoms, but it is not a diagnosis. 2 or more of the following symptoms are necessary before you can classify the baby to be in distress. In a neonate, they breathe normally at 40 to 60 breaths per minute, and the baby is deemed to be tachypneic if this exceeds 60 per minute. Expiratory grunt is often heard as the baby tries to increase the functional residual capacity of the lungs by breathing and expiring against a closed glottis. Chest recessions or retractions may be seen, which is usually intercostal and subcostal, but in severe cases, sternal recession may also be noted. If there are signs of upper airway obstruction, the recessions might also be supraclavicular. Nasal flaring is often seen, and then if you check the saturations of the baby should be cyanosed in room air for it to be significant distress. Also note that respiratory distress and respiratory failure in neonates differs from children, as children with expiratory grunting is on the verge of collapse, while it is a normal coping mechanism in the neonatal period. When a baby has signs of respiratory distress, it's important to make the correct diagnosis. You may need a detailed history from the antenatal course of the pregnancy, as well as the delivery and the transition and the need for resuscitation after birth. You need to examine the baby carefully for any other related signs, and then choose the correct investigations to help you prove your differential diagnosis. In considering the management of these babies, always start with supportive care and prevent hypothermia, especially in the preterm infants. Ensure that the baby is euglycemic so that there's enough energy to maintain all these metabolic systems. Consider fluids, and especially for babies in severe distress, the baby should be kept nil by mouth and receive intravenous maintenance. Normal acid-base status should also be maintained. Continuous monitoring, especially of the oxygen saturation of the baby, should continue, and increased requirements of oxygen should be reported to the doctor. Administration of oxygen and respiratory support will depend on the severity and the cause of the disorder, and the correct method needs to be chosen to best support the specific infant. Saturation should be maintained between 90 and 94%, and hypoxia and hyperoxia should be prevented. Transient tachypnea of the newborn, or wet lung syndrome, is present in 1 to 2% of all newborn infants and is largely due to maladaptation of the respiratory system at birth that then cause retention of fluid in the lungs, which will lead to signs of respiratory distress. It's very important to keep in mind the normal physiology. The mature lung switches from lung fluid production to fluid absorption at the end of gestation, and due to the catecholamine surge in labor, the lungs are already prepared to be born and to start breathing air. So this is the single most important factor in TTN. Secondly, fluid is also squeezed out of the upper airways in a normal delivery, and it can be as much as 20 to 30 mils of amniotic fluid that is removed in that manner. And then the first cry is very important, as the negative pressure of minus 60 to 90 centimeters of water actually serves to move fluid from the alveolar space into the lung interstitium, where it is then carried away by the lymphatic system. Anything that interferes with this normal physiology will then predispose the baby to have transient tachypnea. When making the diagnosis of transient tachypnea of the newborn, it's important to keep in mind the history and predisposing factors. This is more common in late preterm babies around 34 to 36 weeks. It's more common in males. And then pre-labor cesarean section is one of the commonest risk factors, as the baby is not yet ready to be born and the lungs are still actively producing lung fluid, and the lungs then remain quite wet. Also seen in breech deliveries. And then with birth asphyxia, the most common reason is the absence of that very first cry, where the fluid is then not moved from the alveolar to the interstitial space. For the same reason, maternal factors like heavy sedation and excessive fluid can also negatively affect the baby's adaptation after birth. The diagnosis of TTN rests on the history, the clinical course of the disease, and then also the chest x-ray. On chest x-ray, due to the interstitial lung fluid, streaky patterns can be found, especially in the perihilar areas. There may be fluid in the lung fissures, and perihilar cuffing can be seen. Sometimes there may also be signs of pleural effusions or cardiomegaly. The treatment of these infants is mostly supportive. Some may only need a bit of supplemental oxygen, whilst others will do well if you give them positive end expiratory pressure via CPAP. The condition usually resolves within 24 to 48 hours, and if it goes beyond that, it is unlikely to be transient tachypnea of the neonate, and another diagnosis should be considered. Respiratory distress syndrome, RDS, also previously known as hyaline membrane disease, is due to a deficiency of surfactant, which causes higher surface tension at the alveolar surface, and this then leads to atelectasis. This will then negatively interfere with the normal exchange of respiratory gases, and then can lead to respiratory distress and respiratory failure. Predisposing factors that needs to be considered are prematurity, which is the most important factor. The more premature a baby is at birth, the more likely they are to have RDS. If the mother did not receive antenatal steroids before the baby's premature birth, the baby will be at a much increased risk. And the steroids are not just there to mature the fetal lung, but it also has other benefits, such as less risk for intraventricular hemorrhage, less risk for patent ductus arteriosus, and also less risk for necrotizing enterocolitis. So it's the single most important preventative factor is to make sure that if a mother goes into labor prematurely, that she immediately receives antenatal steroids, and to preferably complete the course. Infants of diabetics are at increased risk of RDS, as the lung maturity is inhibited by the presence of high insulin levels. Antepartum hemorrhage, second twin are also risk factors. And then, very importantly, anything that stops the production of surfactant, which is a continuous process in the lungs, such as hypoxia, acidosis, or a baby in shock, can worsen or then elicit RDS. It is commonly known that male premature babies have higher morbidity and mortality rates, and one of these reasons is that they are more likely to have RDS because of the presence of testosterone that also inhibits the maturity of the lung. Pre-labor cesarean section can also contribute to this condition. The signs of respiratory distress can be present from birth, but it can also worsen within the first 6 hours of life to reach a peak severity at 48 to 72 hours of life. It's important to consider that these babies can tire easily and fatigue because of the increased effort of breathing. As the lungs keep on collapsing with atelectasis at the end of every breath, the baby then has to use a lot of force to try and open up the alveoli by expiratory grunting, tachypnea. And then this may actually worsen until the baby is too tired to breathe and can have apnea attacks. On the X-ray, you can make the definitive diagnosis by identifying small lung volumes due to the constant collapse of the lungs, as well as a fine reticular or granular reticular pattern, which is described as ground glass pattern, which affects both lungs equally. You can then also follow out the air bronchograms. Due to the collapsed alveoli, you can clearly see the air in the bronchiole. And then in the most severe cases, you can have complete opacification. The old classification, which just helps you to describe the pattern better, said that grade 1 would affect both lungs with a few air bronchograms. Grade 2 HMD would have more dense reticular pattern with air bronchograms that you can follow out. Grade 3 it would be impossible to make out the right side of the heart, and grade 4 would be as dense as the liver, as seen in the bottom X-ray on the slide. In considering the management of respiratory distress syndrome, there are two big groups, namely supportive and definitive treatment. During supportive treatment, one aims to prevent any hypothermia and hypoglycemia in a neonate, as well as to resolve the metabolic acidosis so that the lungs can keep on producing the little surfactant that it can, and so that these synthesis is not negatively affected by the baby's unstable state. Giving positive end expiratory pressure from birth, with other words from the labor ward, until you admit the baby in the high care unit and can put the baby on the CPAP machine is very important. Oxygen delivery should be such that you aim for SATs between 90 and 94% of the transition from intrauterine to extrauterine life is complete. The definitive treatment, however, is to give surfactant as a replacement therapy. We aim to give this as an early rescue dose, which means that it must be given within the first hour or two after birth. So firstly, you need a history, clinical examination, and also preferably chest x-ray proof that you are dealing with RDS. If the baby then still needs more than 40% oxygen 1 or 2 hours after birth, this is already an indication to give surfactant. The surfactant that we use commonly in South Africa is Survanto, which comes from a bovine source, and the Curacao from porcine. And this is introduced into the lungs via the endotracheal tube and the trachea, and it works nearly immediately to improve the compliance of the lung and lessen the baby's respiratory distress and risk for respiratory failure. Congenital pneumonia is a common cause for respiratory distress in the neonatal period, and it might be infecting agents such as viral, bacterial, or fungal agents, but most often in neonates we see bacterial infections. It can be acquired congenitally due to ascending infection with prolonged rupture of membranes, specifically more than 18 hours, or it could also be acquired, which would then be nosocomial infection or ventilator-associated infection. The most common pathogens found are gram-negative bacilli such as E. coli, Klebsiella, Pseudomonas, and Serratias, which all occur on the perineal area of women, as well as group B strep, which can give you quite a significant pneumonia with severe distress. Staphylococcal infections can also be seen. Again, it's important to start with a history. Any woman in labor with fever, a tender uterus, offensive discharge, or offensive liquor should be clearly evaluated and the newborn screened then for sepsis. The radiological appearance of a congenital pneumonia can be very nonspecific and difficult to distinguish from RDS or even meconium aspiration syndrome. So the history again remains very important. Patchopacifications can be seen affecting both lungs, as it is a bronchopneumonic type of a picture, and lobar pneumonia is very rarely seen. The treatment is supportive, again making sure that the baby is stable regarding temperature, oxygenation, etc. But the specific treatment then is to administer broad-spectrum antibiotics such as Pen-G and gentamicin or ampicillin and amikacin, and then to de-escalate as soon as you have a positive culture, and then to treat according to culture and sensitivity. Very important to again be aware of antibiotic stewardship and to choose the correct antibiotic and to administer it for the correct period of time. There are a few disorders that can be classified as pulmonary air leaks. So the term refers to a collection of gas outside of the pulmonary compartment, and the pathophysiology is similar. It's usually related to stretching of the alveoli that then become hyperinflated and can then burst or rupture, and then the air can escape into either the lung interstitium or it can track along the perivascular spaces to cause a pneumothorax or a pneumomediastinum. There are a few associated conditions. So in respiratory distress syndrome, for instance, you have very stiff lungs with poor compliance, and it's easy then to injure them. In hyperinflated lungs, such as meconium aspiration syndrome, the alveoli are already stretched, and if you exert any more pressure, they can easily rupture. Hypoplastic lungs, such as seen with diaphragmatic hernia or in chronic oligohydramnios, again lead to very small lungs that can easily be damaged. Any ventilatory support is a risk factor, especially during the resuscitation phase, where excessive volume or pressure can easily cause an air leak. And then some babies have it spontaneously after birth. Up to 1% of vaginal deliveries and 1.5% of cesarean section babies might have a pneumothorax. Clinical features of a pneumothorax is that it is can be asymptomatic and incidental finding on X-ray, but when it becomes a tension pneumo, there can be worsening respiratory distress with cyanosis, hypercarbia, and then also poor perfusion and bradycardia. One might identify asymmetrical chest expansion and asymmetrical air entry. And then in a tension pneumo, you can also have mediastinal shift with shifting of the trachea and the heart sounds that can be displaced. It is notoriously difficult to diagnose a pneumothorax. One could try transillumination in the ward, where you put a light source on the baby's chest, as seen in the first photograph. On the contralateral side, where there is no pneumothorax, the halo will be much smaller. One could also try a diagnostic thoracentesis by placing a butterfly needle into the second intercostal space mid-clavicular line with the tail of the butterfly under sterile water. When air bubbles escape, you know that there must be air surrounding the lung. The definitive diagnosis, however, if you can do a mobile X-ray, is to check on the X-ray AP and lateral views to look for air surrounding the lung, and you can clearly see that there are no lung markings in the pneumothorax area. And then the treatment would be to insert an intercostal chest drain and repeat the X-ray to make sure that the pneumothorax is resolving. Meconium aspiration syndrome is a very serious cause of respiratory distress in the newborn period. It usually affects term or post-term babies that had fetal distress in utero, which leads to a passage of meconium in the amniotic fluid. The fetus in distress will then gasp this fluid in and out, and then can have a meconium aspiration syndrome after birth. Not all babies born through meconium stained glycol will have the syndrome, and only 4 to 5% of babies will actually then progress to have severe morbidity and mortality because of MAS. The pathogenesis of the respiratory distress because of the meconium is as follows. Firstly, there can be atelectasis due to plugging of the airways by the meconium. There can be hyperinflation either to compensate for all the atelectatic areas or due to ball valve obstruction where air can enter into the alveoli during active inspiration, but where the partially blocked bronchioli can then fall flat during passive expiration. Due to this, atelectatic areas might be perfused, or then areas of hyperinflation might have limited capillary perfusion, and this will then lead to a ventilation perfusion mismatch that can lead to persistent pulmonary hypertension of the newborn. Another factor to consider is that meconium can inactivate the surfactant and therefore cause poor compliance of the lungs. Because of the hyperinflation, pneumothoraxes are common, and then on the second, third day of life, there can be a chemical pneumonitis due to the irritating effects of the meconium. And then lastly, the lungs can be injured that can cause a secondary bacterial infection. On chest x-ray, meconium aspiration has a very specific pattern. You can identify hyperinflation of the lungs by looking at the flattened diaphragms, widened rib spaces, and increased posterior rib count. You expect normal lungs to have around 9 posterior ribs, and if it exceeds that, the lungs are clearly overstretched. There's usually diffuse patchy opacifications with coarse infiltrates that looks sort of snowstorm or woolly. And then remember to also be on the lookout for pneumothorax or signs of mediastinal air. The management is very important. During the resuscitation in labor ward, you will follow the normal algorithm, and there's no intrapartum or routine tracheal suctioning required, even if the baby is delivered in a depressed state. It is only when you think that meconium is actually obstructing the airway that you will intubate and suction from below the vocal cords. Many of these babies will need ventilatory support, and in this case oxygen is your friend. As the risk for persistent fetal circulation is so high, oxygen helps to relax the pulmonary vascular bed and prevent this from happening. If the baby is difficult to ventilate, one could also consider to give exogenous surfactant, as the meconium can inactivate the normal endogenous surfactant that is present in the lungs. And then very gentle ventilation techniques due to the risk of pneumothorax. And if the baby suddenly deteriorates while being ventilated, emergency x-ray should be taken to exclude this complication. Fetal lung development depends on breathing movements made by the fetus from very early in gestation, as well as the production of lung fluid by the alveolar membranes, and then the in and out breathing of the amniotic fluid, where the lung fluid and amniotic fluid will then mix. Causes for pulmonary hyperplasia, therefore, interferes with any of these factors in normal development, such as no fetal breathing, as you would find in neuromuscular disorders. If there's an inability to expand the lungs, such as seen in diaphragmatic hernia or bilateral pleural effusions, can lead to hyperplasia. And then a lack of amniotic fluid, again, such as Potter syndrome, where there's renal agenesis, or posterior urethral valves that can obstruct the flow of amniotic fluid, or even prolonged rupture of membranes with oliguria can lead to pulmonary hyperplasia. This can be incompatible with life. Pulmonary hemorrhage in the neonatal period is a serious complication that is often fatal. The most important predisposing factors are prematurity, respiratory distress syndrome, as well as exogenous surfactant. The pathogenesis can be classified as hemodynamic. You can have an acute hemorrhagic pulmonary edema that can be brought on by heart failure, as well as increased blood flow to the pulmonary bed, as you would find in a large PDA. Or it can be hematological, which is aggravated then by DIC in a patient with sepsis or coagulopathy. The treatment again reverts to resuscitating the baby well, to ventilate the baby with high positive end expiratory pressures to try and tampen out the bleed, to correct coagulation disturbances, and because the blood can also inactivate surfactant, one can then paradoxically again administer surfactant to try and improve oxygenation. Congenital diaphragmatic hernia happens due to a failure of the normal diaphragmatic development with a persistent pleuroperitoneal canal that is usually more common on the left-hand side, as on the right the liver actually makes a natural separation in this canal. The result is that abdominal contents can herniate into the chest cavity and then compress the lung with resulting lung hyperplasia. The signs that you most commonly see is a history of polyhydramnios, and this condition can be diagnosed antenatally on sonar. These babies might have severe respiratory distress. You can see a scaphoid abdomen, dextrocardia with heart sounds more clearly heard to the right of the sternum can be present, and then obviously if you hear bowel sounds in the thorax, it could be an indication that of the hernia, and then a definitive diagnosis is made on chest x-ray. When treating a baby with a suspected congenital diaphragmatic hernia, it's important to avoid bag mask ventilation at all costs. If you do mask ventilation, you can overcome the natural sphincters tone of the esophagus and therefore also pump air into the bowels, which will then further compress the already hyperplastic lungs and that can negatively affect your gaseous exchange and cause severe hypoxia. These babies need intubation quite often, and with this gentle ventilatory support in order to avoid a pneumothorax in this already compromised hyperplastic lungs. Pulmonary hypertension is very common, and then these babies are referred to the pediatric surgeons, and if the baby has enough lung capacity to survive the surgery, they can then reduce the bowels and repair the defects in the diaphragm. The prognosis can be very poor, especially if the baby is diagnosed with respiratory distress due to the hernia in the first 6 hours of life. There's a high mortality of up to 70%, whereas babies that present after 6 hours and up to 24 hours have a much better prognosis with mortality rates of around 10 to 15%. Esophageal atresia is a congenital abnormality where there is interruption of the esophagus with resulting proximal and distal esophageal pouches. In 85% of cases, there will be a tracheoesophageal fistula present between the tracheobronchial tree and the distal esophagus. It is important to evaluate these babies for associated abnormalities, namely the Vactral association. So vertebral abnormalities can be excluded by looking at the x-rays. One should examine the perineal area for anorectal malformations. All these babies should receive cardiac ultrasound to exclude cardiovascular abnormalities. And then renal anomalies can be excluded by performing renal ultrasounds, and limb defects can also be present. When managing a baby with esophageal atresia, it is important to prevent aspiration of fluid or milk into the lungs. So firstly, the baby must be nil per os and must be on intravenous maintenance fluids. Secondly, the positioning is important. The baby should be nursed supine with the head up at about 60 degrees. In the upper pouch, it's important to put in a replogal tube, which is a double lumen tube with a suction port. Or if that is not available, you can insert 2 nasogastric tubes into the upper pouch, of which one is open and the other one is on continuous suctioning to keep on removing secretions and saliva from that upper pouch. It's important to remember that fluid from the stomach can actually run back through the fistula and enter the lungs to cause a chemical pneumonitis and aspiration pneumonia. And this must be prevented by correct positioning of the patient. When you have a baby with esophageal atresia and a TOF, it is important to avoid ventilation at all costs, as with positive pressure ventilation, every breath will actually lead to distension of the stomach, and it's impossible to aspirate the air from the stomach. And this can then cause splinting of the diaphragms and inhibit the normal respiratory adaptation. If you have a baby without a TOF, as you can see in the picture on the right, then you can more easily ventilate the baby, as the gastric distension will not be possible. These babies need to be referred for surgery, either primary repair or then with the esophagostomy and then a tying off of the fistula with a feeding gastrostomy. And this is usually indicated if the proximal and distal pouches are very far apart. Quite a difficult surgery to do, and the babies can have numerous complications. And these babies are also known to have recurrent strictures of the esophageal repair, and therefore need constant follow-up and regular dilatations. Chronic lung disease is a non-specific term that indicates that various conditions have led to chronic respiratory compromise, whereas bronchopulmonary dysplasia is very specific to premature infants that usually had respiratory distress syndrome after birth. So BPD is multifactorial in preterm infants, but it's especially seen in babies with respiratory distress syndrome, and especially if they were ventilated. Due to antenatal steroids, early surfactant administration, and gentle ventilation techniques, we do not see the typical BPD with lots of lung fibrosis and severe damage to the lungs, but we rather refer to this as the new BPD, where there is an arrest in lung development. The diagnosis of BPD is made when the baby is oxygen dependent after 36 weeks gestational age. The management is to support the baby's respiratory system oxygenating well and to prevent pulmonary hypertension and heart failure. Nutritional support is very important, as we often fluid restrict to prevent fluid overload in the lungs and heart, but because of the increased respiratory distress and requirements, nutritional support is very important, and the dietitian can be consulted to make sure that the baby's caloric needs are met. Diuretics may be tried as a trial to see if it helps the baby's lungs to adapt, and then as a last resort, one can give steroids to decrease the inflammatory process, but the big concern is that there might be neurodevelopmental problems and a risk for cerebral palsy. Newborn babies can have different breathing patterns, and it's important to distinguish between them. Regular breathing would be equal breath-to-breath intervals, but especially preterm babies can have irregular patterns. And then you have periodic breathing, where there are cycles of hyperventilation interspersed with periods of hypoventilation, but these pauses in breathing only last a few seconds. In apnea, however, there is a cessation of breathing for 20 seconds or more, or it can be for less than 20 seconds, but accompanied then by desaturation, which can lead to bradycardia. It's important to just class it in the 4 basic types of apnea, namely central, obstructive, mixed, or reflex. And then it's easy to think of examples. In the central group, 25% of apnea cases are due to central factors that can affect the respiratory center in the brainstem or even the higher centers in the cerebral cortex. The obstructive group is common in about 15% of cases, as babies are obligatory nasal breathers, and anything that can obstruct the upper airway can then progress to apnea. In the mixed group, which is the most common in up to 60% of cases, there can be numerous factors involved. Apnea of prematurity is a diagnosis of exclusion, usually in the smaller preterm infants where the brainstem is just still very immature and does not respond adequately to hypercapnia or hypoxia. Then reflex apnea we see quite often. This occurs with vagal stimulation, which can occur during vigorous suctioning of the nasopharynx, but it can also happen with a baby passing stools or having gastroesophageal reflux. When managing an acute episode of apnea, it is important to check your patient and make sure that the baby is not breathing and that it is not just an error with your monitoring equipment. If the baby is not breathing and is hypoxic and or bradycardic, you can start with basic resuscitation, again putting the baby in an area that you can clearly observe them with the head in a neutral position. Check the airway and clear it if necessary. Then stimulate the baby to breathe by rubbing the baby or flicking or tapping the feet. And then if the baby is not responding to stimulation and an open airway, you must start with positive pressure ventilation and add oxygen as required to maintain the SATs between 90 and 94%. If the pulse rate does not pick up and it remains less than 60 beats per minute, you can start with chest compressions, and if the pulse rate does not recover, you will have to administer adrenaline. Other principles of treatment is then to establish the cause of the apnea and to treat the cause. If the baby was hypoglycemic, obviously he will not recover unless you've corrected that. Or if there were secretions in the upper airway, you need to resolve that. Then you need to prevent further apnea attacks, and especially in preterm babies, it's important to make sure that they are receiving aminophylline, which is our intravenous medication, or then oral caffeine to stimulate their breathing and strengthen the diaphragmatic movement. In recurrent apnea, the babies might need ventilatory support. CPAP can be helpful, especially in obstructive apnea, or if it then occurs recurrently, the baby might need mechanical ventilation. Sudden infant death syndrome is where an infant dies unexpectedly between the ages of 1 month and 1 year of age, and despite history, examination, post-mortem, a medical cause cannot be found. It is important to take preventative measures, and the most important drives to prevent and limit the impact of sudden infant death syndrome is the Back to Sleep campaign, which is now updated to the Safe to Sleep campaign. Just by changing the sleeping position to the supine position on a firm surface has had an impressive and significant effect on the rates of SIDS. Now to the Safe to Sleep campaign, they have added that no soft toys, cushions, duvets, or even cot bumpers should be in the cot area, and avoidance of tobacco smoke and exposure to secondary tobacco smoke is absolutely important. Overwrapping and overheating should be avoided, as that increases the production of CO2. And then breastfeeding is protective, so breastfeeding should always be advised. And then room sharing for 6 to 12 months is advised, so that you are there to observe the baby during the night and to be around when the baby becomes distressed for any reason. But they do not recommend that a baby shares the bed with the parents. And then a pacifier is also protective. Upper airway obstruction can be divided into groups according to the site of the lesion. So firstly, in the nasal or nasopharyngeal area, it may be related to choanal atresia or stenosis. At the level of the oropharynx, conditions such as micrognathia or a large tongue might be to blame. Laryngeal lesions such as laryngomalacia, vocal cord paralysis, or laryngeal web might cause obstruction. And then on tracheal level, tracheomalacia is most commonly seen. The clinical features are quite similar. The baby might have noisy breathing or stertor. Stridor is also a very common symptom, which is mostly inspiratory. There might be suprasternal, sternal, and supraclavicular retractions, and also deep subcostal recessions as the baby is trying to move air. And then a croupy cough or hoarse cry might be heard, and feeding difficulties might be experienced. Choanal atresia is a developmental problem affecting the nasal airways, and it can be membranous or bony. And as babies are obligatory nasal breathers for the first 3 to 6 months of life, this is a life-threatening condition and a medical, basically, emergency. It is important to diagnose this as soon as possible after birth, and then to also look for associated abnormalities as described by the CHARGE syndrome acronym. So firstly, there might be coloboma of the eyes or eyelids. The babies might need a cardiac ultrasound to exclude heart disease. Choanal atresia is obviously the first presenting complaint. There might be retardation of growth and development. Genital abnormalities may be seen, and again, this must be excluded with at least a renal ultrasound. And the babies can also have ear abnormalities and related hearing loss. It must be quite clear that the respiratory physiology is heavily dependent on the prenatal development of the respiratory system, which happens in phases and is only completed after birth. So firstly, you have the embryonic period, which transitions to the pseudoglandular period. The canalicular period from 16 to 24 weeks is where respiratory bronchiolae are formed. And then at around 24 weeks, the saccular stage, alveolar ducts are formed, and this is usually when the baby becomes viable and where surfactant production starts. This then transitions to the alveolar period at around 36 to 38 weeks gestational age, where the alveolar sacs are formed and gaseous exchange is much improved. Pulmonary surfactant is synthesized and secreted into the alveoli by type 2 pneumocytes, and it is quite a complex composition, of which phospholipids make out 85% of the composition. And this is mostly dipalmitoyl phosphatidylcholine, or DPPC, which is the predominant phospholipid in surfactant. Then there is 10% that is protein, and specifically surfactant protein B and C has to do with the function and dispersion of surfactant in order to lower the surface tension. However, surfactant A and D is also very important, as it plays a role in the lung defense barrier. Let's just review the acid-base balance, and please make it easy so that you can remember. On an arterial gas, you expect the pH to be around 7.4. The CO2 on an arterial blood gas is 35 to 45 millimeters mercury, and if you look at a venous sample, you can probably subtract around 10 millimeters mercury. On the PaO2 for term baby should be between 60 and 80 millimeters mercury, and a little bit lower in preterm infants of 55 to 75 is acceptable. The bicarbonate should be at around 20 millimoles per liter, and the base excess anything from 0 to -5. So when you interpret a blood gas, make sure to firstly ask the question, is there acidosis or alkalosis present? Then you want to distinguish between metabolic and respiratory, and then you need to decide whether compensation has taken place or not. Respiratory failure can be defined as a major abnormality in gaseous exchange that can result then in hypoxemia, hypocarbia, and acidosis. Hypoxemia might be due to respiratory or cardiac abnormalities, and therefore hypocarbia is a better indicator of a baby with respiratory failure, and it might be used as an indication of when to then intervene and ventilate a patient, especially if this hypocarbia contributes to acidosis with a pH falling less than 7.25. The causes for respiratory failure are vast, but there are 5 basic groups to consider. Firstly, there might be poor respiratory effort, as we often see with preterm babies or in patients that are suppressed centrally. There might be significant lung pathology. The one that we have already named is respiratory distress syndrome, where the fatigue due to the poor lung compliance can actually then lead to failure and apnea. Abnormal airways, such as with infections or obstruction of the airways through meconium or pneumothorax, can lead to failure. Hypoplastic lungs, again we've discussed hypoplastic lungs associated with diaphragmatic hernia or prolonged rupture of membranes, might not be able to sustain the body processes and might be incompatible with life. Then a small thoracic volume for whatever reason. Examples here would be a baby with large omphalocele or with thanatophoric dysplasia or chondrodystrophic dwarfism. The thorax might be malformed, and therefore the baby will not also be less likely to survive. When managing a neonate with respiratory failure, one can consider oxygen therapy through non-invasive means, such as nasal prongs, or to administer continuous positive airway pressure. However, if the baby is in severe failure, invasive mechanical ventilation may be required. The whole aim of oxygen therapy and supporting of the baby's respiratory system is to achieve adequate tissue oxygenation without causing excessive oxygen toxicity and oxidative stress. And obviously you want to limit the amount of injury done to the lung tissues, especially when you have to support the baby with invasive means. Continuous positive airway pressure is where a continuous distending pressure is applied to the respiratory system in a spontaneously breathing baby. The aim is to maintain patency of the airways and to avoid the end expiratory alveolar collapse, and therefore to improve the functional residual capacity by continuously applying positive end expiratory pressure. The indications for CPAP is as non-invasive support in a baby with respiratory distress. It can also be used to facilitate the extubation of a baby who is being ventilated, and it can be used to treat mild apnea. There are certain contraindications for the use of CPAP, and firstly, if you have a severe or prolonged apnea, it may not be able to help the baby. If the baby has very poor respiratory drive, especially due to central suppression or depression, it may not be adequate. In respiratory failure, the baby might just be too ill for CPAP to work, and invasive ventilation might be indicated. In a baby with upper airway abnormalities, such as guanal atresia, obviously it will not work. And then to be cautious with tracheoesophageal fistula, as the increased pressure will transmit to the stomach and cause gastric distension. In babies that are very unstable and shocked, it might not be the best choice. And then remember to avoid CPAP in babies with abdominal distension, such as ileus and especially necrotizing enterocolitis, as you may increase the risk of bowel perforation. There are also complications to CPAP. So firstly, If there is overdistension of alveoli, it can lead to air leaks, such as a pneumothorax. It may also lead to gastric distension, and it can then also induce vomiting. Hypercapnia may result, especially if the baby does not have a strong respiratory drive. And then something that we see too often is nasal septum injury due to pressure necrosis, due to the tight fitting nasal mask on the baby's nose. Nasal secretions or mucus plugs can form, and then there might also be a loss of pressure if the baby lies with the mouth open. So it's always important to evaluate a baby closely for any of these related complications. Although mechanical ventilation is a last resort, it might be necessary if the baby cannot respond to oxygen therapy via nasal prongs or then the CPAP machine. So the overarching goals are to facilitate gas exchange and to decrease the work of breathing. It will also serve to overcome atelectasis whilst avoiding ventilator-induced lung injury. And then it's also important to make sure that the patient is comfortable and coordinating and cooperating with a mechanical ventilator. It is important to always choose appropriate ventilation strategies and to minimize the lung injury induced by the ventilators. Firstly, volley trauma, which is especially injurious to preterm lungs. We will aim for tidal volumes in a neonate of 4 to 6 milliliters per kilogram. And if you exceed that, especially 8 mils per kilo, you can induce significant damage to the immature lung. Barotrauma, when you use too high pressures, might be injurious. And then atelectasis trauma, which can be avoided by using adequate positive end expiratory pressure values. Biotrauma, in which you can include oxygen toxicities, anything that damages and causes inflammation in the lungs. Some of this already happens before the baby is born, for instance, chorioamnionitis. And then rheotrauma, which is due to turbulent or excessive gas flow. So always important to try and prevent this from happening, as this will predispose the baby then to chronic lung disease and bronchopulmonary dysplasia. When examining a neonate for cardiovascular disorders, it is important to remember the normal physiological adaptation that takes place in the cardiovascular system after birth. The cardiac output of a patient, which is the volume of blood ejected from the heart per minute, is measured in milliliters per minute and is defined as the stroke volume in milliliters per heartbeat times the heart rate in beats per minute. This cardiac output undergoes numerous changes after the birth of a baby. So in the neonatal period, the right ventricle will face less afterload due to the drop in pulmonary vascular resistance under the influence of oxygen. With the ligation of the umbilical cord, the left ventricle will then face systemic pressures, which is much higher than what was experienced in fetal life. Therefore, the cardiac output increases and the cardiac performance is near the upper limit of its range, which means that the baby cannot really compensate in the neonatal period. When considering the stroke volume or the volume ejected per heartbeat, it is quite a complicated interdependent situation. So you have firstly the preload, which is the stretching of the heart in diastole, and which is influenced by the vascular volume and the venous return to the heart. Then you can also consider afterload, which is the resistance against which the ventricle then has to pump. And factors that might affect this is the peripheral vascular resistance and also the viscosity of the blood. And then lastly, you can have the contractility of the heart, which is the function of the heart muscle, which is also dependent then on the preload and afterload. The blood pressure is important to maintain the fusion of all the vital organs. And in the definition, it is the blood flow times the peripheral resistance that can affect your blood pressure. So again, important to remember all these numerous changes that take place after birth. Babies often present with hypertension in the neonatal ward. It is important to remember that organ perfusion is actually the critical factor. But because we cannot measure organ perfusion or determine vascular resistance, we use blood pressure as a physiological parameter to help us make the decision on whether the organs are properly perfused. For this reason, it's very important to examine the baby for clinical signs that can lead you to expect failure of organ perfusion. If a baby is hypoxic or ischemic, it will lead to anaerobic metabolism with lactate production and resulting metabolic acidosis. Due to underperfusion of the kidneys, there can be acute kidney injury or acute tubular necrosis that can lead to reduced urine output that is present as oliguria or even anuria. Babies can be examined for skin perfusion by checking the capillary refill time that should be less than 3 seconds, or by looking at signs on the skin such as mottling of the skin or cutis marmorata as seen in the picture. When there is reduced gut perfusion, it may lead to a risk for NEC. And then lastly, one can examine the central nervous system, and if there is a suppressed level of consciousness, it could indicate underperfusion of the baby's brain and therefore encephalopathic picture. It is sometimes very difficult to establish whether a neonate has hypertension or not. Always start with the technical aspects and ensure that the cuff is the right size for the patient. Then, when you are sure that there's hypertension present or there is evidence of poor organ perfusion, one can consider appropriate management by looking at the different factors such as preload, afterload, contractility of the heart, and the heart rate. The first line of treatment could be volume replacement, especially if the baby is expected to be hypovolemic. In this case, one can administer crystalloid fluids such as normal saline or Ringer's lactate at a dose of 10 ml per kilogram that we usually administer over 30 to 60 minutes. When considering inotropic agents, it's important to remember the action of the different medications. Dopamine, for instance, has a dose-dependent action with dopaminergic effects at the lower ranges that can then positively affect the renal, coronary, and gastrointestinal blood flow. At higher doses, it will stimulate beta-1 receptors that can increase the contractility of the myocardium and can increase the heart rate. And when exceeding 15 micrograms per kilogram per minute, one can then have alpha effects that will increase the peripheral vascular resistance and will increase the blood pressure. Dobutamine has mainly beta-2 effects, and it increases the myocardial contractility, but it also leads to reduced systemic resistance, which can paradoxically then decrease the blood pressure but increase the organ perfusion. So it's a question of balance. Then we are using noradrenaline and adrenaline more aggressively in newborns these days, as it has alpha and beta effects. If this does not work, one can consider using steroids, specifically hydrocortisone, that can aid as adrenal dysfunction and insufficiency might lead to a deficiency in stress hormones that can maintain the baby's blood pressure. Hypertension is quite a rare finding in a neonate, but one can consider the most common causes, namely vascular, and one condition that you have to be on the lookout for is coarctation of the aorta that will give you hypertension in the right arm, but then relatively low blood pressure in the lower limbs and the left arm. Renal conditions are the most common reason for hypertension in the neonatal period, including renal vein thrombosis, obstructive uropathy, and polycystic kidney disease. Drugs should be considered, and drugs that we use quite often is corticosteroids that we might also use for hypoglycemic patients that can then lead to hypertension, and then caffeine that we give to prevent apnea of prematurity can also cause hypertension in the newborn. Endocrine pheochromocytoma we don't see very often, and then just to take note that patients with bronchopulmonary dysplasia due to chronic hypoxia can also develop hypertension, and this can present even months after the baby's discharge. When evaluating a baby for congenital heart disease, there are different investigations that can aid you in your diagnosis. Firstly, especially if you're in a small unit, you can use chest x-ray to look at the size of the heart and work out the cardiothoracic index. The abnormal heart shape might point you towards the correct diagnosis. It's important to look at the vascularity of the lungs and determine whether there is increased blood flow to the lungs or if the lungs are oligemic with decreased blood flow. The position of the heart should also be checked, as well as vertebral abnormalities. An ECG can be done, and then a nitrogen washout test or hyperoxia test can be performed if you suspect a cyanotic heart lesion. So if you have respiratory distress with cyanosis, it can either be a respiratory problem or a cardiovascular problem or pulmonary hypertension, which is somewhere in between. For this test, you will do a blood gas to determine the PaO2 and then administer 100% oxygen for 10 minutes, followed then by a repeat blood gas. If the PaO2 increases to 600 millimeters mercury, it means that it's a normal baby with normal lungs. If there's intrinsic lung disease, it will increase to 150 to 400 millimeters mercury. But then if there is a left to right shunt, with other words a cyanotic heart lesion, there should be no change in the PaO2 as the blood is diverted away from the lungs and therefore cannot pick up the 100% oxygen. One complication of this test is that if you have a duct-dependent heart lesion, it can be detrimental to the baby, and therefore you must have prostaglandin on site to open up a PDA if the baby's condition worsens during this test. In the end, the baby will need to be referred for echocardiography of the heart for a heart sonar, and they might then also decide to do cardiac catheterization if they cannot make a diagnosis on the heart sonar alone. When evaluating a baby for cyanotic heart disease, you can consider three groups of causes. The first is a right to left shunt with restrictive pulmonary blood flow, as you would see in tetralogy of Fallot or tricuspid and pulmonary atresia. There can also be abnormal connections, as you would see with transposition of the great arteries, or common mixing conditions, such as a truncus arteriosus or a massive AVSD. Transposition of the great arteries is the commonest heart defect that presents with cyanosis in the newborn, where the aorta arises from the right ventricle and the pulmonary artery from the left ventricle, and in this case there are then two different circulations that depends on mixing of the blood at a different level, such as an ASD, VSD or a PDA. Because of the increased lung blood flow, they present early with signs of heart failure, and on the X-ray they have a very typical pattern of the egg on side with increased vascular markings. On the management, you need to keep the ductus arteriosus open. The cardiologist will perform a septostomy to enable blood to mix on atrial level, and then they can also consider referral to cardiothoracics for early surgery. Babies with a diagnosis of tetralogy of Fallot usually present later due to absence of cardiac failure in early neonatal and infancy periods. On the X-ray, you can usually see a boot-shaped heart and decreased vascular markings, and this is due to the combination of abnormalities seen in the heart, namely the ventricular septal defect with an overriding aorta, pulmonary stenosis with right ventricular hypertrophy. the babies are often sent home without this diagnosis being made, only to present later with worsening cyanosis and tetralogy spells. When considering acyanotic congenital heart lesions, the ventricular septal defect, or VSD, is one of the commonest at 40% of cardiac abnormalities. In this case, there is a connection between the left and the right ventricle, with a shunt of blood from the left to the right, and therefore an increase of flow to the lungs via the pulmonary artery. This will lead to pulmonary hypertension that can subsequently lead to heart failure. These babies may not be picked up at birth due to the relatively high pulmonary vascular resistance, but as the vascular resistance naturally falls in the first year of life, the pressures decrease, and therefore you can hear the murmur, and these babies can then present with heart failure. About 70% will close spontaneously, but a small proportion of patients will then need surgical closure in early childhood. The patent ductus arteriosus, or PDA, is the most common lesion found in the neonatal ward. In a normal neonate, the ductus arteriosus functionally closes at 10 to 15 hours after birth, but it obliterates and anatomically closes only by 5 to 7 days. There is a left to right shunt where blood moves from the aorta through the ductus arteriosus and into the pulmonary arteries, which will then increase the flow of blood to the lungs, with increased return to the left atrium. Heart failure is common due to the overflow of blood to the lungs. The clinical features in a baby with a PDA is typically bounding pulses with a wide pulse pressure, as seen by a blood pressure where the systolic and the diastolic readings are wide apart. There can be a hyperdynamic precordium, and the systolic murmur is usually ejection systolic in the preterm infant. Later, a diastolic component can develop as blood is moving to and fro through the PDA, and this gives the machinery type murmur. In the management strategy, it's important to avoid fluid overload, as this can worsen the cardiac failure, and restriction of fluids might aid in the closure of the PDA. In most babies, it closes spontaneously, and therefore it might not need any intervention. In babies that have respiratory compromise or severe heart failure, medical closure can be considered with prostaglandin synthetase inhibitors such as brufen and indomethacin. And then lastly, there can be surgical ligation of the patent duct if it does not resolve and increases the risk of cardiac failure. In coarctation of the aorta, there is an anatomical narrowing of the descending aorta that is most commonly found at the site of the ductus arteriosus. This condition can be associated with bicuspid aortic valve and VSD. In severe obstruction, the blood can enter the descending aorta retrograde through the PDA, and that explains why the baby presents in severe heart failure and shock if the PDA starts closing. In clinical features, you can expect to find weak femoral pulses and absent foot pulses. The blood pressure may be higher in the right arm than in the legs, and therefore a forelimb blood pressure check is indicated. The oxygen sats may also be lower in the legs than in the right arm, which is the preductal arm. In the management strategy, it's important to open the PDA with prostaglandin E1, and then surgery is indicated, especially if the coarctation becomes critical with severe obstruction. There is a wide differential diagnosis for congestive heart failure in the newborn period. You can divide the causes into 4 main groups to help you remember. Firstly, there can be left to right shunts, as you would see with a PDA and a VSD, and these patients are typically acyanotic. The obstructive lesions can include coarctation of the aorta or interrupted aortic arch. The abnormal drainage would be total anomalous pulmonary venous drainage, which can be a cyanotic lesion. And lastly, pump failure, as we would see with myocardial ischemia in a baby with birth asphyxia. Hypoglycemia can contribute to pump failure due to energy depletion of the heart muscle. And lastly, then cardiomyopathy. But as you can see in the textbook, there is a very long list. When making the diagnosis of congestive heart failure, you must consider the history and the examination of the baby. You can ask the mother regarding feeding difficulties, especially a baby tiring during feeds or sweating during feeds, and the baby can also look breathless to the mother. Because of these feeding difficulties, as well as the increased work of breathing and signs of cardiac failure, the baby might have failure to thrive with inadequate weight gain. On the vital signs, the baby can have tachypnea and also tachycardia. In the general examination, the baby may appear pale or peripherally cyanosed. Edema can be present, especially periorbitally, and also including the dorsum of the hands, the dorsum of the feet, pitting edema over the lower extremities, and sacral edema. Because of this, you can also have inappropriate weight gain. The poor perfusion can lead to peripheral cyanosis and poor pulses, pulse volumes. Then you might have a vigorous precordium, and a triple or gallop rhythm can be heard on auscultation. Cardiomegaly may also be present. Related systems can also give a clue, as the baby might be in respiratory distress due to pulmonary edema and might have mid-tone crepitations. On the abdominal exam, you can feel for hepatomegaly, and here the liver should have a round edge due to congestion, and it can be tender to touch. When managing a baby with congestive heart failure, one should always start with general supportive measures. This would include oxygen therapy and respiratory support, correction of metabolic acidosis. We often fluid restrict to prevent fluid overload in the heart. And then it is important to also focus on nutrition by consulting with a dietitian and giving high energy milk or supplementation to breast milk. Blood transfusions may be needed, especially if the HB drops below 12 grams per deciliter. This is to enable the baby good oxygen carrying capacity. This must be individualized. Medications that may be used, firstly diuretics. Furosemide and spironolactone is most commonly used combination. The electrolytes have to be checked when the baby is using these diuretics, and then ACE inhibitors like captopril may be used to reduce the afterload, but these babies must be carefully monitored for hypotension. Persistent pulmonary hypertension of the newborn is usually the result of poor adaptation of the newborn from intrauterine to extrauterine life. Any condition that interferes with a normal transition and that can lead to poor oxygenation and poor lung expansion may delay and prevent the physiological drop in the pulmonary vascular resistance. If this does not happen, there may be a persistence of shunts, specifically in the interatrial area through the foramen ovale or through the ductus arteriosus, that can lead to severe hypoxia, which will further aggravate the problem. Under the etiology, there are some primary and then secondary causes. The primary or idiopathic group, there may be primary muscular hypertrophy and can account for about 20% of cases. More commonly, it may be seen secondary to lung disease. Some of the most common conditions would be meconium aspiration syndrome, severe respiratory distress syndrome, or chronic lung disease. It is also a well-known factor in diaphragmatic hernia due to lung hyperplasia. It may also be secondary to infections such as pneumonia, and specifically group B strep is known to lead to a shock lung with pulmonary hypertension. It may be secondary to impaired transition at birth, which we commonly see in babies with hypoxic ischemic encephalopathy who suffer from metabolic acidosis. Hypoglycemia and polycythemia are other reasons that can impair this normal physiological process. Lastly, drugs can also induce pulmonary hypertension, specifically prostaglandin synthetase inhibitors such as ibuprofen or aspirin, and therefore it is contraindicated to give this to the mother. The clinical features of a baby with persistent pulmonary hypertension of the newborn depends on the underlying cause. Affected babies usually present with severe hypoxia and signs of respiratory distress. When considering the management of a baby with pulmonary hypertension, one should focus one's efforts towards treating the underlying cause. A few general management strategies can also assist. Firstly, the baby should be monitored very well with pre- and post-ductal saturation monitoring. If there is a discrepancy of more than 10%, it indicates a shunt from right to left through the patent ductus arteriosus. One can correct the hypothermia, hypoglycemia, as well as electrolyte or mineral abnormalities. Metabolic acidosis will worsen pulmonary hypertension, and therefore this could also be corrected. If a baby is polycythemic, it may lead to hyperviscosity syndrome that can aggravate the symptoms, and this should be treated according to guidelines. Specific management strategies include oxygen therapy, and here one can aim slightly higher, namely 70 to 100 millimeters mercury of partial pressure of oxygen on a blood gas. It is important to give appropriate ventilatory support, especially if the hypoxia is severe, and this will also enable proper management of hypercarbia. It is important to maintain a good systemic blood pressure, as hypotension can worsen the right to left shunting. Inotropes such as dopamine and or dobutamine can be given to support the baby's circulatory blood pressure. Lastly, one can administer pulmonary vasodilators such as sildenafil, which we use quite often, as we do not have access to inhaled nitric oxide or ECMO. Other medications that can be considered is magnesium sulfate and milrinone.